Good morning, everybody. I am Dr. Vijaya Kumar Reddy from Sunshine Hospital. Today we are going to do a case of TAVI in an 80-year-old gentleman who is having severe calcific degenerative aortic stenosis with hypertension post-CABG in 2005 with Lima to LED grafts and SVG to OM and SVG to RCA. Now patient is having class 3 symptoms, is having dyspnea and having history of recurrent syncopal attacks. So in view of a patient is having Alzheimer's disease, and in view of the severe comorbid conditions, we advised him a TAVR. We assessed his parameters. Echo shows a very severe aortic stenosis with a peak gradient of 105 and a mean gradient of 74, and the normal LV systolic function and the normal LV systolic function, and EF is around 58, and renal parameters are essentially normal. HB was 12.1 grams and the platelet was 1.5 and serum creatinine was 1.1 and eGFR 57. We assessed the STS score and Euro score. STS score was 8.7, which indicates a high risk for SAVR, and the Euro score 2 was 7.53. So ECG is showing left ventricular hypertrophy with strain pattern, and we assessed the CT angio of this patient. The most important essential thing in case of TAVR is the assessment of the aortic valve and aorta by CT angiogram. Here we have to assess the aortic annulus, sinus of Valsalva, the distance from the annulus to the coronary ostia and the sinotubular junctions, and the external iliac and common femoral artery for vascular access. These are the very most important, crucial things to assess what type of access you should do. Usually transfemoral access is most of the times used. If it is not feasible, there are alternative access like axillary, subclavian, carotid, and transcaval and transapical access, but these are not good access. But transfemoral access is the most important, and the success rate is very high. The annulus is the 24.9 the diameter. The sinotubular junction was 26.8. The maximum ascending aorta was 32.7, and sinus of Valsalva was 24.7, and the height of the coronary ostia right is 16.3 and left is 20.6. There is very ideal. The ostial side should be more than 10 millimeters to avoid any coronary occlusion. Here the ostial height is very much in favor of TAVI, and the diameter of common iliac artery is 8.1 and external iliac artery was 7.1 and the coronal femoral artery was 6.3, and right side and the left side is also the same parameters, which indicates a favorable transfemoral access for doing TAVI. So based on these parameters, we have chosen a 24 Evolute R TAVI valve to deploy for this patient. Evolute R is a porcine based prosthetic valve made by Medtronic company, which can be delivered by 18 French sheath, and here it is a supraannular valve. There are two types of valves for TAVI. One is annular and supraannular valves. This is Evolute R is a supraannular valve, and the Hydra valve also that is made in India is also a supraannular, whereas the other valves, that is My valve and Edward Sapien, are annular valves. So we have chosen a supraannular valve. The major complications of TAVI was paravalvular leak and the need for permanent pacemakers. Because of the newer technologies and the better thing, the incidence of complete valve block has been less than 1%. And here the technical aspects is we have to put femoral vein and femoral artery access on the right side, and femoral artery on the left side. We have to the balloon tip temporary pacemaker, rapid pacing, and we have to do aortic root angio by passing a pectoral catheter through the left femoral artery. and we have to cross the most important step is crossing the aortic wall by using AL1 with straight tip thermowire. After crossing, it should be exchanged with confida wire, which is a tail shaped wire, and over the wire, and we have to deploy the valve, and we have to assess any paravalvular leak. And patient should be having dual antiplatelet tests for 3 to 6 months, followed by lifelong single antiplatelet drugs. This is the technical dissect of the patient.